Hello, welcome everybody. We are getting started shortly. I'm seeing folks still coming in, streaming in, so we'll give that a few moments. Okay, I believe we are here. Thank you everyone for joining. Welcome, welcome. I'm Phil Chang, and I'm the president of the Sleep Research Society Foundation, and I'm so pleased to welcome and thank you for joining today's industry scientific seminar. The SRS Foundation is very excited to be able to host this series of educational webinars where attendees like yourself will learn the science behind a sleep product and how it works directly from our industry scientists with a question and answer opportunity. So as we are getting started, let us go ahead and explore how our shared mission of growing knowledge can help further our field. So please note that the SRS and the SRS Foundation do not endorse any products discussed on today's webinar. So without further ado, today we'll be learning about dawn of a new era targeting the neuromuscular root cause of OSA with oral pharmacotherapy presented by Apnimed. Now, I'm so pleased to be able to introduce and turn over the webinar to Dr. John Cronin. Take it away.
Thank you, Dr. Chang, and thank you to the SRS for providing us with this opportunity. It's really fantastic to be here today, but also for all your stewardship for the scientific efforts in our field. So thank you very much. As Dr. Chang mentioned, my name is John Cronin. I am a sleep specialist. Currently, I am the Senior Vice President of Clinical Development at Apnimed. Just a bit about Apnimed. We are a small but mighty team, about 70 strong, based in Cambridge, Massachusetts. We're a biotech company that's really dedicated to the discovery, development, and ultimate commercialization of novel oral therapies to address the neurobiologic mechanisms of sleep-related breathing diseases. And so, our mission really is a long-standing one in the sense that this has been uh, sort of a holy grail of our scientific field to develop a medication to treat sleep apnea. Decades, international efforts ongoing, but it was really hatched about 7 years ago through some sleep scientists at the Brigham and Women's Hospital, which ultimately landed on data that was so compelling and so interesting that really was the beginning of the company and of Apnimed. And since that time, we've been able to progress our programs fully, and I'm really excited to be able to share with you today the results of our phase 3 program, which was recently presented at CHEST back in October of this past year with our study chair people, Patrick Strollo and Sanjay Patel. So before we get into that, I think what I'd like to do is simply give you a sense of context and our worldview of why we're doing what we're doing and how we're doing it and how we're going about it. And really, this starts with the disease. And I'm sure many people on this call are well aware of OSA, probably international experts in it on their own right, but just some level setting to really understand that, of course, OSA is an incredibly common disease. The most recent estimates indicate there's about 80 million US adults with the condition. That's not the least of which to mention the estimated 1 billion people with OSA globally. I think Dr. Banjefeld previously explored that in a publication. This affects men and women, men a little bit more than women, but only slightly so. Certainly, it's prevalent across all age groups, but slightly more prevalent as you get older. And then, as a surprise to many people, that obesity is really a risk factor for OSA. But there's also many people, in fact, the majority of people in the community that have OSA do not meet the obesity criteria of a BMI greater than 30. And then finally, symptoms are certainly all important for those people that have them, but we also recognize a lot of heterogeneity in that sense that many people simply don't have symptoms with OSA, or their symptoms don't correlate with the severity of their OSA, which is always a clinical reality that is sometimes hard to deal with and understand. Taking a step back, looking at the public health considerations of OSA, Again, if we start at the top and we understand that there's an estimated 80 million US adults with OSA, and then we look at the diagnostic penetrance, and this is the AASM's own sort of metric looking at roughly about a 20% diagnostic penetrance. So that means most people remain undiagnosed. I don't think that's too much of a surprise finding, but it's certainly an important one for our medical services and our clinical field. And then when we finally get to that 20% that's diagnosed, we look at their treatment realities. Certainly, it's always interesting to note that about a quarter of people never fulfill their CPAP prescription for a variety of reasons. Some refuse, some are intolerant, some are deemed not to be good candidates and simply aren't treated. Of those 74% that get a CPAP prescription, long term, after about 1 year, we appreciate that the majority of patients remain undertreated. About 37% maintain good, sufficient therapy over the long haul, whereas a large portion of patients either underutilize the therapy or discontinue the therapy. And it's really in this group. So these patients are diagnosed, they want to be treated, they've raised their hand, they are seeking care for their condition, yet they haven't been able to take advantage of the standard of care. And while we all recognize that that standard of care is really critical, it's a transformative therapy for those patients, we do revisit and come back to this group. And this is a large part of our why at Apnimed as to what are we going to offer these patients who really want to be helped but simply haven't been able to find success with what they currently have. And then certainly as we drop down into that undiagnosed group, it's that's a big reservoir of patients that we need to figure out how to best manage and get into the care funnel if possible. So turning a little bit towards our more specific worldview at Apnimed, again, we are really interested in the neurobiology of sleep and breathing. And we want to highlight the importance of the sleep-related neuromuscular dysfunction that is known to occur in OSA. This is a key pathophysiologic consideration of the condition, really highlighted by by a number of factors. Number one is that we do have a sleep-related reduction in neuromuscular tone that it can allow an anatomical airway to collapse. Furthermore, we reduce the airway's ability to respond to a challenge. So when an airway does start to close, a normal airway might respond to that and activate the muscles, where those with OSA have diminished reflexes. And then finally, there's some evidence to this if we look at pathologic changes in upper airway muscular and myopathy that can accompany OSA. So it's one or more of these that contributes to what we consider sort of neuromuscular dysfunction. And that leads us to sort of a framework of OSA, sort of a two-factor framework, which really requires the combination of two key things. One, obviously, is the underlying physical anatomy of the airway. Most people are well versed in this, but whether it's large tonsils, adiposity of the upper airway, the tongue, centripetal obesity, craniofacial malformation, these types of things lead to a narrowed airway that almost by definition requires a neuromuscular deficit that does not allow that airway to be protected at night. So these two factors somewhat collide at nighttime, and in the wrong person leads to an obstructed airway, as many on this call already know. And so really, again, these two factors, the sleep-related neuromuscular dysfunction, this predisposing anatomic abnormality, leads to airway collapse, mostly measured by AHI. This chronic intermittent hypoxia that stems from that, so the downstream sequelae, really is the body's reaction to this, which can include a myriad of sort of cascading realities of inflammation, HIF-1 activation, endothelial dysfunction, sympathetic and systemic inflammation that occurs, which ultimately gives rise to a heterogeneous mix of downstream sequelae. Just clicking a little bit further into some of the metrics. Obviously, most people are aware of apnea-hypopnea index, which really represents a key event-based metric similar to the oxygen desaturation index. These simply are counting the number of events but really remain kind of the standard historically as to how we define the severity of the condition in a direct correlation. The more events, the more severe. But over time now, we've begun to learn that there are other ways to more holistically understand the risk to patients, their symptoms, and their long-term sequelae. And those are typically oxygen-based measures, hypoxic burden. I think most people on the call have certainly heard of this, which is really gaining more traction, more literature, more scientific inquiry to understand that it not only complements AHI in many respects, but might even be superior in terms of understanding what patients find most worrisome about their health. Hypoxic burden itself really looks at the duration, depth, and frequency of low oxygen, which is a little bit more of a rich metric than simply the event-based metrics. Furthermore, I think if we look at the clinical utility of all this is essentially that when we look at the things that concern patients is that, the long-term health risks of OSA are probably best captured by these oxygenation metrics pictured here, whether it's ODI, but really hypoxic burden in T90, which seem to have a stronger association with serious health consequences, and in this case, cardiovascular and all-cause mortality being better predicted by those measures as measured on a sleep study. And really, this corresponds and really slots into what patients tell us they see as being important. And this is data that we collected as part of a SHINE survey, which was the largest study conducted looking at the sleep health needs and emotions of patients with OSA. And you can see really a heterogeneous mix of considerations, mostly long-term health consequences, and whether that's dying because of OSA or some of the cardiovascular or brain issues that can be linked to OSA. I think as a field, we've done a pretty good job at highlighting that for patients, and they are worried. To augment that, certainly most people are well aware of some of the day-to-day concerns, whether it's symptoms or the impact on your function, broad symptom consideration, fatigue, sleepiness, depressive symptoms, snoring as a symptom. And then certainly a bit of a revelation for me and being involved in this work is really to understand how this affects people's relationships, essentially causing them to be somewhat dislocated, sometimes from their family, their friends, their community, simply because they have this condition, which can be accompanied by stigma and things like that. So more than enough reasons to treat this condition. And as we think about treatments and we think about coupling that with our prior framework, we can sort of mechanistically put these into context. So I think we're all aware of upper airway surgeries, oral appliance therapy, and now the recent emergence of medical weight loss at scale with the GLP-1 agonists. These are all predominantly targeting the physical components of the anatomy that can add pressure on the airway towards collapse. Whereas on the other end of the spectrum, we have hypoglossal nerve stimulation, which selectively and in a more direct fashion tries to target the neuromuscular dysfunction OSA. And then pictured at the bottom really is CPAP, which it doesn't mechanistically have a specific role here other than the fact that it indiscriminately opens the airway successfully in the patients that can tolerate it. Okay, so getting to the meat of things here, we're going to begin talking about 8109. 8109 is basically our code name for this compound. It is an oral investigational agent that we have termed an anti-apneic neuromuscular modulator. It's designed to target the neuromuscular dysfunction of the upper airway muscles during sleep by combining two compounds, pictured here are oxybutynin, which is a novel antimuscarinic designed to stabilize the upper airway in sleep. It is an R enantiomer of oxybutynin, which you may have either used clinically or seen historically. simply because it has seen to have a preferential anticholinergic effect in that R enantiomer. And that's coupled with atomoxetine, which is a selective norepinephrine reuptake inhibitor, which promotes adrenergic tone and muscle activation in the upper airway during sleep. So these two compounds are combined into a single agent taken at night, approximately 30 minutes before bedtime. And here we have just a pictorial of sort of the mechanistic activity. The atomoxetine blocks the norepinephrine reuptake inhibitor, increasing the norepinephrine levels during sleep, which typically are more depleted during sleep. And again, this helps activate muscular tone. And the R-oxybutynin blocks acetylcholine signaling, which is active during sleep, particularly REM sleep, and has a relaxation signal to the genioglossus. So by blocking that, we blunt that relaxation, and together these two compounds work synergistically to open and stabilize the airway during sleep. So just as a quick summary, we've hit a couple key points of the fact that OSA is very common, is clinically heterogeneous, and that despite the fact that PAP therapy is fantastic for many patients, there's an incredible number of patients that need new solutions in a way that targets therapies on their terms. And in doing so, we've designed 8109 to really target this neuromuscular dysfunction of OSA, really to help drive airway patency and improve oxygenation and the downstream effects of that condition. And what I'm going to do now is essentially help you walk through the clinical picture that's emerging with 8109. And again, this is part of data that was presented at CHEST in Chicago last month, or actually in October, and is currently under process towards publication. There's much more data to come, and we're excited about that, but I'm going to present for you our data package as it was in Chicago. A little bit about our clinical program. So we're wrapping up our phase 3 clinical program at Apnimed, which is evaluating the safety and efficacy of 8109 in the treatment of OSA. But prior to this, we've done numerous phase 2 studies, probably best highlighted by the Mariposa study, published approximately 2 years ago. This study was a 1-month efficacy and safety study, which was quite reassuring to us in terms of our programmatic progress. And the phase 3 study now builds upon that as an extension to demonstrate longer-term efficacy and safety, both for patients as well as regulators. And then finally, both of these phase 3 studies have an open label extension that's currently ongoing, where subjects who can exit the two main studies and then receive open label drug, and that will further inform our longer term view of both efficacy and safety. And I want to make one key point is that we really wanted to study and develop a drug for number one, for the patients that need it, number two, for the patients that can benefit from it. And in that mind, what we're really looking at patients with mild, moderate, and severe OSA, really across a wide range of weight classes from normal weight upwards to a BMI of 40, just to help understand where this compound might be of help most to clinicians and patients. Just a quick blurb about the actual study. So we had 2 phase 3 studies, Synergy, which was a 6-month study, and Lunero, which was a 1-year study. These were the 2 largest studies of pharmacotherapy and OSA conducted to date. And they were largely based in North America. Synergy was conducted in the US and Canada, and Lunero was conducted entirely in the US. In terms of key enrollment criteria, basically, we kept it as broad as we possibly could while trying to really hone in and study this broad range of OSA in adults age 18 or greater with an AHI greater than 5. We didn't want to confound this, nor did we think that there would be any impact on central or mixed apnea. So when clearly apparent, we excluded that. as well as periodic limb movements, as noted. We did want to capture some degree of symptomology, and so we used the PROMIS fatigue measure, which is a psychometrically valid instrument that we'll talk a little bit about during the presentation. But this raw score cutoff essentially represents a population average fatigue level of about 50%. So we recruited people with at least very, very mild fatigue as opposed to totally asymptomatic patients. And probably the most important thing of our program really is the fact that we conducted this in patients who were either refusing CPAP or failed CPAP trial in the past. We captured a wide range of BMI from 18.5 to as much as 42 in women and 40 in men. And then you can see, I'll highlight with the key exclusion criteria that essentially we have wanted to exclude other very significant sleep disorders that might confound some of our findings, as well as clear anatomical considerations of OSA that might impact any neuromuscular manipulation towards improvement. And then as it relates to cardiovascular morbidity, we did exclude patients who had significant or untreated unstable coronary artery disease, heart failure, recent CV events, or revascularization within the past 3 months. And we excluded patients with blood pressure over 145/90, although I will mention that patients could be included into the protocol with hypertension, provided that it was controlled. And we have roughly about 50% of the subjects in the study had hypertension on entry, granted it was controlled. Just a pictorial here to understand graphically what our study looked like. And really, the studies are fairly straightforward in design, I would say. I'm going to just show you here graphically. You can see we had a screening period heralded by a PSG, where a subject would be eligible for enrollment if they had an AHI greater than 5. They would then be randomized in a 1-to-1 fashion. They would either receive placebo or 8109. The way 8109 is dosed is at a run-in dose, which reflects a lower dose of atomoxetine, which is consistent with atomoxetine's current labeling for other conditions, followed by transitioning after 1 week to the full dose. And this would be the full treatment dose. Patients weren't allowed to go up or down after this dose. And they essentially would stay on this until week 26 in Synergy and week 51 in Lunaro study. I will highlight that the primary endpoint as part of our statistical plan was designated as this 26-week endpoint. And in the Lunaro study, we did continue to assess blinded safety data as well as a PSG for efficacy at week 51. And getting to those endpoints, the primary endpoint really was change from baseline in AHI-4 at week 26. Key secondary endpoints that I've somewhat highlighted clinically before this include oxygenation changes in from baseline in hypoxic burden as well as ODI. In terms of looking at clinical meaningfulness, we established an analysis looking at the proportion of participants with a reduction in AHI greater than 50. And we also looked at patient-reported symptom outcomes around the PROMIS fatigue measure as well as the PROMIS sleep impairment measure. And I think, yeah, so that's what I wanted to know. So this is an important but detailed slide to talk about, and this really sets up the data discussion. And so we look here in the 2 columns. We have the treatment policy estimate on the left and the on-treatment estimate on the right. The treatment policy estimate on the left is really the most pure conservative approach to any clinical trial, generally favored by regulators and scientists. And really, this essentially takes any patient that was randomized in our study and received at least 1 dose of 8109 or placebo. They are analyzed in that group. Even if you stopped the study or the drug the next day, you would still be counted in that group as if the treatment effect represented that arm of the study. And the data analysis is really regardless of adherence to treatment. If there is imputed data, if there is missing data, it's imputed after the fact. And the way we did that for any of subjects in this treatment policy estimate is they would be imputed from the placebo group. So even if you were in the 8109 group and you discontinued the medication and you had missing assessments, you would be given the placebo group assessments. Ultimately, very conservative, again, preferred by regulators. That is a little different than the on-treatment estimate. The on-treatment estimate might be a little bit more akin to what some people might recognize as like a modified intention to treat analysis. And this, again, takes a slightly different descriptor set. Every patient who is randomized and received at least one dose of 8109 and had at least one post-treatment PSG to understand the treatment effect. And that data collected after treatment discontinuation would be set to could be set to missing if it was unavailable, and that the missing data would be imputed from a method called last observation carried forward, so that we would retain their earlier treatment effect to understand what their current treatment effect is. So these two models are going to be put forward to you as you look at the data to understand. Ultimately, the on-treatment estimate reflects sort of a little bit more of a real-world scenario where this is what patients would more likely experience if they stay on the drug, whereas the treatment policy estimate, again, is that more pure scientifically conservative approach favored by regulators and scientists. So let's get to some of the data. So this is baseline demographics. Pictured here on the left is Synergy, Lunaro on the right. Quite similar in general. You can see that the 8109 and placebo arms match up quite nicely. Essentially, we have a very classic OSA patient, at least as represented by our own prior clinical programs and as the field. Average age of 57, BMI, mean BMI of 32, and you can see the breakdown. Again, we really studied a broad range of BMIs, noting that about 66% of the subjects were technically classified as having obesity with a BMI greater than 30. In general, this group had moderate OSA as a group mean of 22 in Synergy and 24 in Lunaro. But that's also explored a little bit more fully here when we look at the various severity levels, mild, moderate, and severe across these two studies. Baseline Epworth score, fairly standard of about 10 throughout these studies. I'm really proud of the team and want to highlight the fact that our study showed an incredible array of diversity that really reflected the race and ethnicity of the United States of America population in general, as well as a very important gender balance. So we had roughly 49% women in one study, and I think 46% women in the other study, which really, in my mind, stands out as a feature that's very important for our field. But also, we didn't specifically recruit women. We didn't specifically try to capture any gender. And so there's something potentially about the protocol and the way it was set up that led people to want to enroll in a more balanced fashion. Okay, so looking at the data. So what I'm going to put in front of you are a number of very consistent slides. So I'm just going to orient you. We're going to see the Synergy generally, and then the Lunaro. The treatment estimate will be listed here, whether it's the treatment policy estimate or in other slides you might see the on-treatment policy estimate. And then obviously the y-axis is going to show you the outcome measure. And then typically we're going to be seeing week 4 and 26 for Synergy, week 13 and 26 and 51 for Lunaro. But again, highlighting and reminding you that our primary outcome is really assessed most intently on week 26. So primary outcome, AHI change from baseline. This is the treatment policy. This is the most conservative descriptor set and analysis that we're looking at. And this was our primary outcome looking at change from baseline. When we look at the synergy study at week 26, we see basically a 4-point reduction, placebo-controlled reduction in AHI4, whereas in Lunaro, we essentially have about a reduction of 4 as well. In both cases, 26 weeks, this was statistically significant as a group mean. Within that mean, there is a lot of heterogeneity, including people with 10, 15, even 20 points of improvement in their AHI. I will note that the 51-week measure here is not statistically significant. We don't believe this represents any loss of efficacy. This is really about the imputation method that's used for the treatment policy estimate, where anyone who dropped out in the second half of the year is essentially then analyzed as having received placebo. Another way to look at this is the AHI percent reduction from baseline. Again, this is using the conservative treatment policy estimate, recognizing some realities of the data that help us better analyze what percent improvement are people seeing. And so with the synergy protocol, we see a 44% reduction in AHI at 26 weeks, followed by Lunaro, which showed a 33.7% reduction in AHI in the more conservative analysis. And again, the 51-week measure did not meet statistical significance related to the imputation method. When we look at the AHI change from baseline on treatment, again, this is the more relevant analysis for those subjects who remain on treatment. We see a more robust response in AHI from baseline at 26 weeks. We see a 6-point reduction in synergy, a 5.8 reduction in Lunaro at 26 weeks. And now with that less conservative imputation of missing data, we start to see the persistence of the efficacy signal at 1 year in Lunaro. Similarly, when we look at the AHI percent reduction, looking at the on-treatment estimate, we see a robust 56% reduction in AHI from baseline compared to Lunaro, which had essentially a 47% reduction from baseline, and again, a result that was sustained at the 1-year mark. Another way that we chose ahead of time to look at treatment response is to examine a 50% reduction, or let's call it a sort of a responder analysis. And this was a bit predicated on some AASM literature and data that suggests that this, at least at face value, it reaches a clinical meaningfulness for patients that's important. And we see here statistical significance that 39% of people had a 50% reduction in synergy, whereas 38% had a 50% reduction in the Lunaro. When we look at the two different studies, again, the result persisted at 51 weeks, and this is the on-treatment estimate. Another way to explore clinical meaningfulness of the data, is to look at disease severity and how that progresses on treatment. And this is a way to capture sort of disease resolution or disease category changes. And so here for the synergy study, looking at the on-treatment estimate, we can see here pictured at baseline the various categories of severity: severe, moderate, mild, and then how those categories changed at both week 4 and week 26, recognizing that in synergy, about 51% of patients improved their disease severity through the treatment course, and roughly about 22%, nearly a quarter of patients resolved their OSA or had their disease controlled defined by an AHI less than 5. And pictured on this side is what we see kind of the natural state of placebo. This is quite similar to what we saw in Lunaro, which you can see, quite similarly. We see about a 45% disease. I'm sorry, 45% of participants had improvement in their disease severity downward, with again roughly close to a quarter of patients achieving disease control with an AHI less than 5. Turning to some of our oxygenation, I think an important finding here, really looking at hypoxic burden using the on-treatment estimate of Synergy. We saw a 60% reduction from baseline in hypoxic burden at week 26. That was closely followed after that with Lunaro study, which showed a 58% reduction. That result was sustained at week 51 as well. And again, this is really seen as a superior marker of both the burden of hypoxemia experienced through OSA as it correlates to longer term health outcomes in OSA. Not too surprising, ODI-3, again, a event-based metric showed a 45% reduction from baseline at week 26 in the Synergy study. And in Lunaro study, we saw a 40% reduction from baseline at week 26, a result that largely is sustained at week 51 to further to further complement our understanding of how 8109 impacts the upper airway and oxygenation. Now, turning to symptoms, again, we used a couple well-validated key psychometric instruments known from the PROMIS family. The PROMIS family is a highly designed and developed psychometrically valid set of instruments that looks at a lot of domains across health and function. In particular, for our program, we looked at PROMIS fatigue, which itself is a very, it's sort of a unidimensional measure looking at just fatigue and how patients experience and see that. We also looked at PROMIS sleep impairment, which is a little bit broader, looks at fatigue, concentration, sleepiness, irritability, these types of concepts that might a little bit more broadly try to capture some symptoms. So here pictured, we have Synergy, and using the on-treatment estimate at week 26, which is again the primary analysis, we see a statistically significant reduction or compared to placebo at week 26 in PROMIS fatigue. This was a p-value of 0.03, so just met statistical significance. That was not replicated in the Lunaro study. So essentially, this was a negative result for the PROMIS fatigue in Lunaro, and just met statistical significance in PROMIS fatigue for Synergy. Interestingly, also mentioned that when you look at the response, we see a very dramatic response in both the drug and placebo arms through this study. These tended to closely approach meaningful changes. It's just that there was no clear separation from placebo in this study. Pictured here is the PROMIS sleep impairment. Unfortunately, disappointment in our study was that at week 26, over the entire population, we did not see a differentiation from placebo in PROMIS sleep impairment in either Synergy or Lunaro. Turning to safety, I think it's important to obviously review a couple key considerations. Treatment emergent adverse events and adverse events across both trials generally and predominantly were mild. There were no serious adverse events related to 8109, which was consistent with our earlier studies. And really the reason why the FDA and others require us to do such long, careful studies so that we can reassure ourselves that in this patient population of OSA patients that using these medications is safe in addition to efficacious. The common AEs listed here are really consistent with prior studies and really reflect the known effects of the SNRIs and the antimuscarinics as classes. You can see dry mouth, insomnia, and nausea as being, some of the more common ones. Uh, Pictured here, really, these are the AEs that at least hit this threshold of 5 events per hour. I'm sorry, not 5 events, 5% 5% of the participants reported this AE as a finding. Now, we also see that many of the AEs occur early in treatment course. So subjects would experience either dry mouth, insomnia, or nausea early, which may impact their willingness to continue into the rest of the protocol. Interestingly, when we talk about insomnia, while we had 20% insomnia in the Synergy trial and 22 or 23% in Lunaro, in terms of discontinuations, only I think it was 4 to 5% of discontinuations were related to that as a side effect. To summarize the kind of overview of the endpoints, we certainly had significant improvements in the AHI from placebo, both in Synergy and Lunaro. We hit key secondary endpoints of hypoxic burden and ODI with strong p-values consistently across both studies, and that we had significant proportions of improvement of AHI greater than 50 in both studies, nice and consistent there. Again, in terms of symptoms across group means, we did not see a differentiation from placebo in Synergy or Lunaro, with the exception of promise fatigue in Synergy. Further analysis of this and publication around this should be expected in the next year. There's some very interesting analyses that look at those patients with more symptoms at baseline. And so one of the realities of our study program is that to a certain extent, we have an overrepresentation of patients that really didn't have much symptoms at baseline, and further pre-specified analyses looking at the more symptomatic group are eagerly awaited as well. And then in terms of exploratory endpoints, I was happy to share with you some of our view of this change in disease severity classification, as well as those who get a complete response or complete control over their OSA with 8109. And then finally, with safety, we recognize that the studies generally indicated that 8109 was well tolerated. Yes, there were AEs like there are with any compound, but these were really consistent with prior studies, mild and manageable. And we're delighted to know that there were no serious adverse events related to 8109, as we know that the OSA population has a lot of potential for different comorbidities across the spectrum. So this is my concluding slide, and I just wanted to kind of come back together and understand kind of where we've gone with this, and as it relates to 8109, that really Apnimed as a company has really targeted this sleep-related neuromuscular dysfunction that helps any airway really adjust to the physical realities of the anatomy that might want to collapse it. But when the airway does collapse, there is this cascade of chronic and intermittent hypoxia that leads to pathophysiology across a heterogeneous range and spectrum for patients. And that through the Synergy and Lunaro trials, the results were both consistent and compelling, demonstrating efficacy and safety of 8109 in this patient population. So with that, I'm going to take a quick breath and turn it over maybe to some questions and answers. If I could, I haven't been able to closely monitor the chat, but I am going to pull it up real quickly just to see what I can try to understand. So here's a question. What about anticholinergic effect on cognition, like confusion? Any events of urinary retention? That's a 100% great question. You know, what we designed and what our prior uh, phase 2 studies looked at is really the most effective dose finding. And obviously, with dose finding, you want to maximize efficacy and reduce the side effects. With R-oxybutynin, because of the enantiomer, we're able to concentrate more of the anticholinergic effect into a lower dose. And through that pathway, we're able to get fewer anticholinergic side effects, preferentially related to the bladder, et cetera. That being said, it is within this class of antimuscarinics, so it is something as an AE that can be anticipated, or I'm sorry, can be experienced, and is part of it would certainly be part of any labeling. For instance, you would want to likely exclude patients who, by labeling, would either be uh, known to have bladder outlet obstruction or might be on medications that might make that more complicating as a consideration. Um, we did measure some safety metrics as part of the phase 3 study, digital substitution tests, some visual learning considerations to try to understand daytime function upon awakening. We saw no signals related to the PVT data, anything like that. The half-life of the R-oxybutynin is roughly 2 to 3 hours. So with a single nightly dose, we think that the pharmacokinetics are fairly favorable for that short-term night use that doesn't seem to impair morning function upon awakening. Okay, let me see here. Next question. Do pharma study participants have the option to continue 8109 treatment after completing the protocol? Our participants followed post-study. So we have the two source protocols, phase 3, one was again 6 months, the other a year. Subjects were eligible to enroll in an open label extension and essentially get access to the open label compound as part of an ongoing clinical trial to, again, continue to monitor for safety, efficacy, as well as tolerability of the compound. So that's ongoing. There is not um, there's not another access program, that expanded access program for other patients just to get on the drug outside of those two clinical trials. Um, we generally excluded patients that had myopathies during the study, so any significant neuromuscular dysfunction, sort of a global neuromuscular condition that might compound, might make it difficult for them to stay into a clinical trial and tolerate these types of treatments. Um, and let's see what else. What did the blood pressure data show? Great question. So from Dr. Schweitzer, who you referenced, she published our phase 2 data. And what we see, and really the results in some respect are fairly consistent and anticipated, both mostly based on the effect of atomoxetine. Atomoxetine is an SNRI and is known to increase heart rate. In our phase 2 study, we see a small increase in heart rate as a group mean of around 3 to 4 beats per minute. Similarly, when we look at ambulatory blood pressure, 24-hour Holter monitor, 24-hour ambulatory blood pressure monitoring, we see roughly about a 2 millimeter increase in mean blood pressure in the 8109 group. And all this is really consistent to what we thought we might see based on what we know about atomoxetine as a compound. We continue to explore that and we'll intend to publish on these factors moving forward. What is the rationale for blocking muscarinic receptors in treating OSA? The rationale really gets again to some of those. Well, there's multiple pathways for CNS control of breathing, but in particular the cholinergic signaling that occurs through the genioglossus and hypoglossal motor neuron into the genioglossus, particularly during REM sleep, and that's an inhibitory signal that causes sleep relaxation. So honestly, it was a theoretical rationale that has been shown now in clinical studies to actually work synergistically together with the norepinephrine reuptake inhibition. Um, there may be other pathways to also approach in that regard, but that's the rationale for that particular pathway. Okay, well, I think we are at the end of our time. Thank you for some great questions. Really excited to explore this data set further through publication. And again, we anticipate getting this into publication in the new year, as well as further ongoing analysis looking at exciting things like endotypes and other items that would certainly fascinate the SRS community as being the leaders in our field. And I definitely want to take a moment to thank the SRS Foundation, Dr. Chang, and the team for allowing us to have this opportunity, first and foremost, but really more broadly for all of your stewardship of our field and how you advance our science. In part, I see some of the work at Apnimed really organically as being part of that broader field effort in OSA care. So thank you very much, and thank you for attending. Bye-bye.